Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be here today in person, near DC in an undisclosed location, with the wonderful Dr. Meena Seshamani, former Director of Medicare. So we've had the Chief Innovation Officer? Chief Strategy Officer?
Transformation Officer.
Chief Transformation Officer at Medicare. Doug Jacobs, and he was on your team, right?
Yes.
He worked with you?
Under me, yeah.
Anyway, so very honored to be here. You literally just stepped off the roll,
3 weeks ago?
Yeah, 3 weeks ago. So this is fresh. We're going to get this thing out. It's going to be really hot topic. So thank you so much for spending the time.
It's my pleasure.
So let's dig into kind of some of the interesting headlines on the news these days are about a lot of the DOGE initiatives, the Department of Government Efficiency, and they're kind of combing through a lot of different departments. I think they started with the DOD, and they're looking at, obviously there's been a lot of news about the USAID department, which I've never heard of until then. And one of the biggest areas that they're going to be focusing on is is not CMS necessarily, but the whole branch, the HHS, right? Health and Human Services. And so what are kind of your thoughts about a lot of people get confused when they hear, when they see these headlines, they just think oh my gosh, there's money being stolen. And so what are kind of the differences how should people be approaching the news and the conversations around this topic? Are there differences in kind of, hey, something was overlooked, a contract that was maybe being paid out and that entity no longer exists, but money's still going somewhere? Is there a difference between incompetence and fraud and just missing money? Give us a little context.
Yeah, so that's a great question. So there are 3 different aspects to where money might not be used in the most effective way. So they're waste, fraud, and abuse. And they're 3 different things. So waste is when you have money that is being spent maybe in not the most efficient or effective way possible. So a good example is that somebody ended up getting the same blood work done twice because there wasn't good coordination between the providers to know that had already been done somewhere else. So, and I think we'll probably get into a lot of that as in our conversation. That's where a lot of the efforts around value-based care and creating more holistic care models really are trying to address some of that waste so that you're spending more money in a smarter way to really drive improved outcomes. So that's waste. Then you have abuse where something is being billed improperly. So there are improper payments, and that's an area where it shouldn't be billed, right? And that's abuse. Fraud is when you have wrongful criminal wrongdoing. So fraud also implies that intent. And that's why, for something to be determined fraud, there is a whole process that one undergoes, with the Department of Justice doing investigations. And so it's important to remember that there are those 3 different avenues. There's waste, there's abuse, there's fraud, and they are distinct. But a lot of times when people are just talking, they kind of lump it all together as one, but it's important to remember that there are 3 distinct things, and how you would go about trying to address them would be different accordingly.
Yeah, that makes a lot of sense. And I think it is really important to delineate those things, because the middle one I think is actually is very this is not new, meaning going after the abuse has been something that the OIG and you guys have done for the longest time, and trying to consistently make sure that people are not taking advantage of these programs. That actually segues directly into something that I planned on speaking about way later, but let's just dive right in. So speaking of abuse, you have done a tremendous job with putting out these different programs that are kind of allowing people, even in a fee-for-service world, to dip their feet into value-based care. Mm-hmm. CMS has put out that by the year 2030, they want everyone to be in some sort of value-based arrangement. And programs like chronic care management, annual wellness visits, transitional care management, these kind of programs that are preventive in nature, seem to me, at least, to be that the intent is to allow people to start getting used to the behaviors of actually caring about the outcome and doing some kind of preventive care. There's obviously room for a lot of abuse in that system. So let's take chronic care management as an example. it's very time-based. And so unfortunately, there are people that will just lie on the logs, or they'll just double time, or they'll just make things up. And that's an area for fraud. But then sometimes CMS will have to overcorrect and kind of bring everything so that there's no fraud. Now we're moving towards this really, really interesting model called the advanced primary care model. Instead of me introing it, do you want to talk a little bit about the advanced primary care model?
Well, I think, what you are highlighting is one of the ways in which the system has not been aligned in the past, where you have, healthcare providers, clinicians who are billing, and you have a different person than the patient paying the bill, right? So you have this triangulation, if you will, between the person who is providing the care, the person who needs the care, and the person who's paying for the care. And because of that triangulation, that is why traditionally there has been all of these various codes, and then doing all of this auditing and oversight to make sure that the codes are being billed appropriately. And what we want to move to is more of accountable care, where someone is in an accountable care relationship where their clinician is accountable for both the quality and the cost of the care that they're providing. And if you move to that level of accountability, then it enables you to, if you will, give a little bit more of a lump sum payment and say, here is some funding so that you can care for someone in the best way that you think that person should be cared for, because ultimately you're going to be held accountable if you end up spending more money than you should, or you're going to reap rewards in savings if you kept this person healthy, you kept them out of the hospital, for example, and you saved money. So that is the idea behind a lot of the value-based care models, behind total cost of care models like accountable care organizations, which we can talk about. And importantly, you can't just have these fancy models and expect that every single person is going to be in these models. You need to actually transform the chassis of the Medicare program so that accountability, and with that accountability comes more flexibility, is ingrained into the chassis. And so that's where we took the first step with these advanced primary care management codes, where in the basics of the physician fee schedule, if a clinician is providing, for example, 24/7 access to care coordination services, and care navigation, then they are eligible to bill for a lump sum payment that is based on the needs of their patient. And then they can utilize those resources as they see fit to be able to provide the best care to their patient. And then they are held accountable to, increasingly held accountable to cost and quality, on that flip side. So that's kind of the idea behind it, to really bring that accountability into the very chassis of the Medicare program.
Yeah. I think one of the most transformational and exciting things about the advanced primary care model is the fact that unintentionally in the minute and time-based programs, efficiency is punished because you have to hit certain times. And then if you could technically have the same outcome for less time, you're not incentivized to do that. And I think one of the biggest shifts, the kind of paradigm shifts that are happening with this new model is a shift in that regard, where now it's actually about the value. It's actually about the outcome. You've taken out those time-based requirements. And I think that as we kind of come together with a lot of, it's happening at a very, very perfect time, because you have all these kind of AI efficiency tools that are coming into place that can allow for things like automatic documentation, a lot of things to be done for the care coordinator or whoever's doing the program. Previously, that would have been punished. And now with the advanced primary care model, that's actually becomes a good thing. And if you could get more patients helped with less time, that's positive, and you're going to get rewarded for that. Was that specific shift, was that part of the intentionality behind the program?
I think it is still a code that is in the physician fee schedule. So there are still various parameters that apply to it. It is a first step towards creating ultimately, a more bundled payment that provides a lump sum. So I think this is the direction where if you have clinicians who are able to take responsibility for the full care of their patient, then it enables the payer to say, okay, like here you go and, manage. And we're happy to help. We have all sorts of technical assistance for clinicians who want to utilize these codes on how to best utilize them. We obviously have all of our auditing and oversight that we continue to do to make sure, again, to what we were talking about, that you don't have, abuse of the system or improper payments. But really, it's an opportunity ultimately to get at the waste, where there are I think all of us who we're all patients too. I'm sure every one of us has an example of where there was something that was like, because care wasn't coordinated, something fell through the cracks. There are opportunities for us to care for our communities in a smarter way so that you're spending that dollar in a smarter way to keep people healthy. And that's ultimately what both these, bigger models are about, and also these changes to the fundamentals of the codes.
Yeah. And so that's really exciting, but let's double click on that for a second, which is why I segued into this. The flip side is, in my view, there is obviously abuse happening on the, on the CCM side, meaning on the time-based code side. That has and although you get punished necessarily for efficiency, it also makes it very easy to audit and find, because you just look at logs. There's only so much that somebody can make up before it just doesn't match, right? So it's very easy to audit. My concern with the new program is I think it all comes down to something that you kind of touched on, and I'm hoping you can dig into, which is, what are those new areas of like from an audit perspective, what are you actually going to be looking for? Because if there's a way to quantify some of those quality metrics and actually say, we expect to see X, and it's impossible not to see X if you're doing the program correctly, right? That's amazing. My concern is, what if there's just now we've only taken out the time requirements and have not replaced that with a more intelligent responsibility or process for auditing. Now the opportunity for abuse is going to go actually much higher. My concern with that is, I'm very excited about this program and I don't want it going anywhere because I think it's in the right direction. So maybe can you speak to that?
Yeah. So there are various requirements for these codes, in terms of what care must be provided, what constitutes advanced primary care for a clinician to be able to bill these codes. And so that is key. And that's where the auditing will look at the clinical documentation and see, are these services being provided that you are essentially billing for? So I think those avenues continue to be in place. And when I was there was a lot of exploration, and, I hope that there will continue to be, on the other thing you raised, which is the quality metrics, the outcomes. Really looking at, one of the things we did was create this, MIPS value pathway, so that in the quality program, there's a set of measurements for a primary care provider. And that's where, if you want to build this advanced primary care code, then you have to be reporting on these set quality requirements and meeting these quality requirements. And importantly, starting to incorporate the total cost of care of a patient into those requirements. So then you're getting to that accountability for overall cost and quality.
And is that built in? So are you saying that's built in? Because the things that I saw on the advanced primary care model was basically just 24/7 access to care plans, care coordination efforts, which could be a variety of things. I think one of the things that was actually interesting was,
but in order to bill you, you have to be reporting on those quality
metrics and showing actual progress.
Yeah, that's like part of the hitting thresholds on the quality metrics. And I think that's an area for continued exploration as we move forward. As you think about what are the things that could be incorporated into this bundled payment, what are the corresponding outcomes that you want to see with it? I think that's an area for continued development.
Yeah. So let's talk about continued development. What is, some areas of the government are obviously extremely polarized, extremely political. Although there maybe aspects at HHS every now and then, it is not a political thing. Healthcare shouldn't be political. Healthcare should be, we're all humans. We all have health. We all want to be healthy. And so there actually seems to be, and this is my own conjecture, you can comment or not, but I feel, and from a lot of the people I'm speaking to, there does seem to be a lot of alignment between your time at HHS and at Center of Medicare and the people that are supposedly coming in now, as far as an emphasis on value-based care, an emphasis on, things like care coordination. I remember thinking back when Vivek was, now he's no longer involved in DOJ, but he's definitely influential in that side of the government. I remember when he was running for president and he was talking about this concept of like dismantling the Department of Education, sending it back to the states. And regardless of where you stand on that issue, the model that he had in mind was literally shared savings. So the model that he had was, we're going to say, okay, it currently costs X amount per pupil for the federal government to teach. Send it back to the states, and if they can do it for cheaper, we'll split the delta with them. And I was like, that's literally shared savings. So it seems like there is a lot of alignment there. What can you speak to as far as shared ground and common vision? And also, second to that, what would be your advice, kind of warm handoff to some of the incoming folks?
Yeah, I think that health is something that impacts every single person in this country. And I was taking care of patients as a head and neck surgeon. Otolaryngologist is the, official term, ear, nose, and throat. Yeah. I was taking care of patients up until I took the job leading the Medicare program. And I really brought the stories of my patients with me to the role. Like, how do we improve care so that you can really have a positive impact on the lives, not only of the people you're caring for, but their families, their communities, because health is something that really is so central to how we live and function. And that's something that I think is common for everyone. And I think we all have common goals of improving care, of improving health, of spending money in a smarter way, enabling people to have access to high quality care. And so I think that very much is the foundation of everything that we all do in healthcare. And, one of the things that was really important to me when I was in the role leading Medicare was really getting out there and listening to everybody who is on the ground, because I was on the ground. I know how important it is to hear from people who are on the front lines, either caring for patients or someone who is a patient or someone who's a caregiver taking care of a patient at home. It's so important to listen to what all the different parts of the healthcare ecosystem are saying, seeing, experiencing, because that helps inform then what you do as a policymaker. And that's why I say I have no pride in authorship of all the things that we did in the Medicare program, because by and large, they were ideas that people gave to us from their own experiences. And I think that is very important for anybody who's coming into these roles to really approach it with an open heart and an open mind and open eyes, so that you can really learn from everyone about where opportunities are. And then when you do make a change in policy, in operations, making sure that everybody knows about that so that they can actually take advantage of it. It's great that we created, for example, care navigation payment codes, or payments to train family caregivers. And we put it in the physician fee schedule. It can sit in the federal register and not make a difference in someone's life. What matters is that now family caregivers know that they can ask their, loved one's clinician, hey, I need help with, doing this wound care for my loved one who came home, from the hospital. Can you help me with that? It's important. And same thing for clinicians to know that these codes are available so that they can get the financial support they need to be able to take better care of their patients. So it really does go both directions. And I think that is critical for all of us together to be able to really make progress in improving healthcare.
This content is brought to you by Careco. I know you've never seen an ad on this show before, but we are so excited. We just launched Careco. We've been working on it for the past year and a half. Careco is an AI co-pilot for care coordinators. We reduce burnouts and increase efficiency by over 40% by only taking the parts of a care coordinator's workflow that are annoying and can be done better by technology and empowering the care coordinator to do more for their patients as a human. We look at it as we're building the brain to amplify the heart. So if you're involved in care coordination at all, please go check out careco.ai. That's our new website. We're really excited about it and hope to see you over there.
So that's a great ideal, but it would seem to me that it's actually quite difficult once you're up in that kind of cocoon of government to actually break out. First of all, there's a lot of red tape and a lot of just bureaucracy with communications. And also, you're one center point. If you open up communications too wide, you're going to be just bombarded with communications. Actually, I visited HHS headquarters during what's that period called when you take suggestions?
Mm-hmm, comment period.
Yeah, comment period. And, and so they were very overwhelmed. So you've got your comment periods, but if you open up that communication too wide, you're going to be overburdened with input. If you shut it down, like you said, now you're disconnected from your end user. So what is kind of the balance? What are some real practical avenues and conduits that you opened up or suggest for them to continue to keep open to create that two-way communication?
Yeah, I mean, this is where the comment periods are very, very important. I mean, the Medicare team reviews tens of thousands of comments with all of the rules and reviews every single comment. I mean, this team is just incredible in the work that they do and their commitment
People
to
don't
this
believe
work.
It, by the way. I was there.
It is incredible. The work that they do, going through the comments, really thinking them through, saying, okay, what makes sense? Where is there, something that would not work given, the statutory authorities, that we have in the Medicare program, et cetera. We also very much try to set up regular avenues for communication. So I'll give you a good example. We had to implement the Inflation Reduction Act, right? The biggest changes to the Medicare prescription drug benefit since it was stood up in 2003. And we had to do it in 2 years or less. So it was very important to us to set up regular meetings. We had quarterly strategic meetings. We had monthly technical meetings. We had an open door policy where people could set up individual meetings with us. And we always said, be concrete, be specific, bring us paper, if there are ideas you want us to consider. So really setting up avenues like that so that you can continue to get input is also very important.
Yeah. So let me ask you a question, and feel free to not answer, or we could literally cut this out entirely. But I don't even know all the details, but during that time period, there was a huge shakeup to the reimbursement calculation that affected Medicare Advantage plans, I believe. And that really negatively affected, I think, a lot of people that, I think ChenMed was really affected. Cano went down. I don't know if entirely because of that, but I think it had a big impact on them. I remember a lot of people being really concerned about that change. Are you able to give some more context to what that was, why that was, and where was the disconnect between the market and the policy?
Yeah, so what you're referring to is changes that we made to the risk adjustment model for Medicare Advantage. So about half of people in Medicare get their Medicare through a private health insurer. And so how that works is Medicare makes a capitated payment, so a payment per enrollee to the health plan to then cover the care, pay for the care for that person. How is that payment made? It's based on several things that are in the Medicare law. There's benchmarks and all this kind of stuff. One aspect of it is risk adjusting that payment. Because if you think about it, if you have somebody who is predicted to cost more money to the health plan, if they're not getting additional money from the government to pay for that person's care, then it could lead to cherry picking, where a health plan is going to say, well, I only want to enroll the healthy people because otherwise it creates too much financial risk for me. So the risk adjustment model basically takes an enrollee's information and predicts how much that person is going to cost to be able to adjust the payment to the health plan accordingly. That risk adjustment model was utilizing data from 2014. It was utilizing the ICD-9 domestic nomenclature. And so what we did was we updated. So instead of 2014 data, we moved it to the most recent data we had, which was 2019, because you should use the most recent data when you're doing these kinds of modeling. We moved from ICD-9 to ICD-10 because nobody was using ICD-10 diagnostic coding anymore. Nobody was using ICD-9.
Is that just diagnosis codes?
It's all the diagnosis codes.
So how would that change?
Correct.
Or whatever, it's just another piece of data, another input that was changed.
Correct. It's another input that we brought to the most, current available that everybody is using. And then the third aspect, and those two aspects making the data more recent from 2014 to 2019 and moving from ICD-9 to ICD-10, that accounted for like 90% of the change in the risk adjustment model. Then we also looked at individual diagnosis codes to say, okay, do these diagnosis codes correlate with increased treatment costs? Because ultimately, what is the purpose of risk adjustment? It's to provide money to those individuals who are going to cost more. Right. So we found that there were some diagnostic codes that did not actually correlate to increased costs. So therefore, those diagnostic codes should not get the increased money. It's other diagnostic codes that should get the increased money.
And small caveat here, they didn't not correlate because they were being well managed due to, like in Medicare Advantage, right? Because that's always like a concern of mine.
No, it's like basically this is how risk adjustment works. It's based on, you're predicting
I'm
what
just saying
the cost
of that thing
be.
didn't go down because they were doing a good job. It just simply didn't correlate.
What we're looking at is if someone has this diagnosis, is the cost of managing them higher?
Right. But if I do a really good job with this demographic, then I push it down.
But then that means that that person is not costing you as much as a plan.
Right.
Right. So like the whole idea of risk adjustment is to prevent cherry picking.
Yes.
So if that person is not costing you, then you need to have the money going to those people who are costing the plan so that they don't cherry pick away from those people. So that's the rationale behind updating the risk adjustment model. It's just to make payments more accurate. And we phased it in so that there wouldn't be a shock to the system. And when you look at the offerings, the premiums, the benefits, everything has remained stable because again, we are using the most current data to be able to enable the risk adjustment program to work properly.
So feel free to stop me if we're getting too deep into this, but the systems that were negatively affected and made a lot of noise about it, were they, did they know that the data was wrong, wasn't updated? And because it sounds like what you're saying is basically just the data wasn't updated the second you just redid that Excel sheet formula, it basically spat out a different number, had nothing to do with policy. So did they know that they were essentially getting a free ride, whatever you want to call it, for a couple of years, and that was going to come to an end, and they were just upset about the fact that it was coming to an end? Or was there lack of communication about the data, and all of a sudden it's like, oh wait, we were working on the premise, we were building this massive health system and models and whatever on the premise that this is what things cost, and now all of a sudden that's changed, and now the whole thing goes. So what's your take?
Well, I don't know that I want to get into like surmising what was the intent of various people. I will say as a health economist that markets respond to, the incentives that organizations within markets respond to the incentives that a market creates. And so, they are going to respond to whatever data is being used for whatever kinds of payments. So if data is being updated, there are going to be changes in the market. Do people like change? If you have something that's working for you, then you're like, well, I just want to keep doing what's working for me, right? That's, human nature. However, the role of a regulatory body is to make sure that you are paying accurately and that you are utilizing the international classification of diseases that is being used by everyone in the healthcare system for a decade. And that you are using the most up-to-date information, because for every person who is, the plan is getting additional money when it doesn't actually correlate with their diagnoses, there's someone else for whom, if the model is not updated, then the risk adjustment model is not reflecting that they actually cost more, and you could end up with cherry picking that adversely impacts them. So that's really the rationale behind making these kinds of updates. They're very thoughtful, common sense, data driven.
You don't think there was a lack of
updates.
communication on the data?
There was definitely, to what we were talking about before, we had an open door to get ideas, to get information. We also put out something called a request for information, where when I came into the role, we asked everybody, what's working well in Medicare Advantage? What are areas for improvement? We got more than 4,000 comments from across the spectrum of the healthcare system. And that's really what we utilized to make changes like these. Two other examples of where we made big improvements with Medicare Advantage, prior authorization. That is something that we heard from everybody about, from patients who are frustrated that they felt there were barriers to getting the care they need, to clinicians who, talked about the burden of jumping through these hoops to try to get their patients care, to health plans that said we need clearer rules of the road so that we know what we can and cannot do. So we made the most significant improvements to prior authorization in decades, where if traditional Medicare has a coverage decision, Medicare Advantage has to follow that. So really streamlining the process where there isn't a coverage decision in Medicare, then Medicare Advantage plans can do prior authorization, but they have to use well-established clinical guidelines and make those clinical guidelines public so that people can evaluate them, et cetera. So again, really thinking about common sense ways to improve these programs. And another area, we talked about risk adjustment, prior authorization. Another area that we heard a lot about was marketing. A lot of consumer complaints about misleading marketing, where people were being switched to a plan. Their clinician is no longer in the network. We heard from clinicians who said, patients are calling up in January wanting to make an appointment, and we have to tell them, oh, you switched plans. We don't contract with that health plan. They're like, wait, I switched plans? When did I switch plans? So we rejected more than 1,500 TV ads that we found to be misleading, because again, we want people to have choice, because healthcare is not a one-size-fits-all, but people need to be able to navigate that choice, to be able to pick what works best for them. And these are all areas of win-wins, because if someone has a negative experience with prior authorization, their health suffers, their clinician is frustrated, their caregiver is overwhelmed, and they get mad at their health plan. So, it really was a win-win to find common sense policy areas for improvement. Similarly with marketing, when that person can no longer see the doctor that they have seen for years, they're going to get mad at the health plan. They're going to get frustrated with their provider, and their health may go down as a result. And so, really finding those win-win areas, it requires, again, everybody having this constructive dialogue to really look at the data and find areas for improvement.
Yeah. This is absolutely wild, because, and I hope, and I'm sure everyone will appreciate, you're one of these people that the more I talk to you, the more questions I have. You're an absolute, a fountain of knowledge. It's it's amazing. I had no prep coming into this, and now I just have so many, we could sit here for 4 hours. So I just know from the CCM side, they should be paying for CCM and they don't. Like most of them. Is there supposed to be a recourse for that? I just took it as okay, what am I gonna do? I'm gonna fight with them?
I don't know the specifics there, but at a higher level, Medicare Advantage must cover everything that traditional Medicare covers in Part A and B.
And if they don't?
Then, that is something that, the CMS team should be made aware of, so that we have our oversight and audit team that can look into areas where are there compliance issues? Is there confusion? Does there need to be clarification, et cetera?
Okay. And then this might be really detailed on CCM, but I actually know that this is a giant point of confusion for people. So maybe you can help clear it up, maybe not. But in the CCM, paperwork, that MLN kind of thing that talks about the different requirements, it uses the term clinical staff as far as people that, and this is common through a couple of different programs that clinical staff can do this. There's a huge argument between all the various brilliant people and lawyers out there on what is the definition of clinical staff. And so some people say they have to be an RN. Some people say they could be nobody, as long as they, in New York, they have a lot of medical assistants. And that's basically what another place they call community health workers, just someone coming in and taking care of patients. My feeling is that sometimes CMS will intentionally create some sort of ambiguity or a gray area in some of these terminologies so that they have the flexibility to kind of determine intent and say, sometimes we see you're doing a really good job and you're living out the soul of the program, the intent of the program, because other people can do the opposite. They can check off every box and not make an inch of a difference in the patient's life. So you kind of, and then others, but CMS, my feeling is that sometimes you, not you, but CMS leaves kind of intentional ambiguity there. Is that the case in general, which might be positive because then sometimes, like I said, it leaves them flexibility. And if not, and in general, if you have any clarity on the whole clinical staff thing.
Yeah, I mean, I don't know the specifics of the clinical staff for the CCM code. In general, this is where there's always an opportunity to ask for clarification. You know, what do you mean by this? You know, does this fit? Does this not fit? So that's where I would encourage, you know, reaching out either to the regional staff or reaching out through the various mailboxes that we have. Medicare Learning Network, you know, a lot of times they'll give, like, if you have further questions, you know, here's how you contact. That would be my suggestion.
Fair enough. Okay, cool. Looking back at your tenure there as the head of Medicare, and I know we touched on a couple of these things, but you know what? Super interesting. Towards the end of your time there is when AI started becoming really relevant, and I'm sure you get questions on this all the time. And I'm not asking for a crystal ball, tell the future, but you're really smart and you have a lot of context around these things. Maybe we could do the same thing we did at the beginning of this conversation. Like, can you give some context to the whole AI conversation? What are kind of the underlying around good AI regulation? How do we make sure that AI regulation doesn't stymie actual innovation? What are maybe in your mind just some bare bone basics that everyone should agree to? How do you approach the whole AI health tech conversation?
At a very high level, I think that AI absolutely has an important role to play in healthcare. I think it can really improve efficiency and thereby like reducing burden for clinicians. It can help to digest the increasingly complex amount of information that people get. And that applies to health plans, it applies to clinicians, it applies to patients, it applies to regulators. I think there also has to be a balance between utilizing these algorithms and realizing that ultimately healthcare is personal, it is individual. You know, as when I was a resident in training, as an attending would say, patients don't read medical textbooks. They don't come into your clinic and say, well, doc, my chief complaint is shortness of breath. And the symptoms that I am having are that I had this weight gain and that my ankles have gotten thicker, right? I mean, nobody presents in that very black and white way. There's a lot of nuance in medicine. I mean, that's why they say the art of medicine. And so being able to strike that balance so that you don't end up with unintended consequences of, you know, an over-reliance, if you will, on an algorithm, and that there's continual learning to continue to refine algorithms and not have, you know, biases of what inputted then be what comes out that then leads to, you know, some potential vicious, you know, or virtuous cycles. So, you know, one example of this is proposals that we have made in Medicare Advantage to really strengthen guardrails around, you know, blanket denials of care. Like that plans can't use, for example, an AI algorithm to deny a claim. There has to be a case-by-case examination by a clinician with relevant clinical expertise in order to ultimately deny a claim. So, you know, that's an example of how I think people have to try to strike a balance between the efficiencies that AI can provide while also making sure that you are accounting for the incredible nuance that exists in healthcare.
What about just building another AI that's specifically trained on countering the counters?
I mean,
for real, like, you know.
That's something that I think can continue to be looked at, right? But I think this is where you always have to examine the data that's going in, you know, to also make sure that you are, you know, getting good outputs coming out, and being able to have that oversight is important.
Yeah, fair enough. That's a really good framework. You've got some exciting news just announced last week. Can we talk about it?
Sure.
Okay, so what is the next stop for the incredible Dr. Meena Seshamani?
So I feel very, very fortunate. I have been named as Secretary of Health for Maryland. So pending confirmation, I would have the incredible opportunity to be able to, improve the health of people in my state, which is near and dear to my heart. I've lived in Maryland. My God, how long have I lived in Maryland? Decades. I've got 2 kids in Maryland public schools. I did my training as an otolaryngologist in the state of Maryland and, practiced, so it's a very, very exciting opportunity to continue to the conversation we've been having, to really continue that momentum. It just means so much to me personally and professionally to have the opportunity to really roll up my sleeves and engage with everyone who wants to make people healthier. And there are so many interesting organizations and people who are really invested in that. And I look forward to the opportunity to being able to continue doing that in my new role, if I'm confirmed.
Yes, that was a great press release. That was perfect. Spot on. How do you kind of approach the difference between going from national mindset to localized somewhat mindset? Because, and it's funny because most people probably have that in the opposite. I'm sure you did as well. When you went up to being head of Medicare, you have to think with so much more context. But now you have all that experience, and it almost feels like it might be even more painful to have to like contract your aperture to the needs of one state. Are there differences, or is that totally just not true?
Well, so before I came in to lead Medicare, I led care transformation for MedStar Health, which is a big health system in the Maryland, DC, Virginia area. And one of the service lines under my portfolio was community health. And I always used to say, what's the first word in community health? Community. Ultimately, healthcare is local. And I think, from my role leading Medicare, it was so important to me to get outside of DC, to go travel and do site visits and visit with people on the ground, because it is so important to see how care actually plays out on the ground. And I think similarly, it's very exciting to potentially be able to be at a state where states really are, the bed of innovation, where you are local, you are seeing on the ground exactly what's going well, where things could be improved. And I think there are huge opportunities for partnership there to really be able to improve care. So I think it's all part of the same, vision and mission to have this continuous learning to be able to improve care. And it's going to continue to be important for everybody to be working together.
Yeah. I think that, as we're kind of building CareCo in general, when you're building tech, it's always so important to keep your end user involved in the process. And so many technologies fail because they don't do that. And like talking to you, you like just completely embody this concept at the policy level. Sounds like this is not, I told you offline, I could usually tell when people are in politics and then they're just saying talking points, but there's been enough of a pattern here that I can confirm that you actually really, really care and are always keeping the actual patient at the end of that long line, sitting all the way at the top as head of Medicare, really in mind. And I think that's really inspirational.
That's why the job was so amazing. And I will tell you, this is the way I, tried to engage with people even when I was in. One of the things that I loved about my job was when I would travel and I would have an elder lady giving me a hug because now her husband could afford his insulin because we implemented the cap, only $35 for covered insulin in Medicare prescription drug coverage, right? That's what all of this is about. The impact that you can have on positive impact that you can have on people's lives. And that's what fueled me and my team every day. And that's what I'm really excited that I will get to jump back into.
Well, thank you so much for the time. Like I said, we could go on for hours. Congratulations to the state of Maryland. And look forward to continuing to chat. Thank you.
Thanks for having me.
Pleasure.